Welcome. Joining the third annual Global Summit, Kidney Innovations, Expanding Patient Choices and Outcomes. Collaboratively, this is being presented by AAKP and George Washington School of Medicine and Sciences. I'm Catherine Campbell. I am an AAKP Ambassador from Texas. I'm retired as a healthcare executive and nursing educator. I'm honored to be part of AAKP. Their mission of education, advocacy, community involvement, and empowering patients is demonstrated in all their activities. I currently am in end-stage renal disease, awaiting a transplant for the last 3.5 years. Because of excellent provider care and compliance with diet and medications, I'm able to stabilize my condition. AAKP is legislatively involved in all aspects of kidney disease. Currently, they are working to ensure the uninsured and the insured to not be discriminated against for donating kidneys. This should impact the availability of more kidneys for transplant. I'm also a member of KPMP, Kidney Precision Medicine Project, which is a research involving biopsies of kidneys, identifying different treatments available for patients. It is not a one treatment for all. It's based on your cell activity and molecular findings. From this biopsy, there is a medication atlas being performed in order to treat patients appropriately. Involved in KPMP, I am on the Community Engagement Committee, where we have contributed significantly to the consent for patients and for insurance should there be any issues following the biopsy participation. Also, the CKD adjudication and clinical operations. At this time, I would like to introduce Vivekanand Shah, Professor, Clinical Nephrologist, Executive Director for the George Institute for Global Health in India. Dr. Shah currently serves as the President for the International Society of Nephrology. Dr. Shah, I'd like you to know that we are all in thoughts and prayers for India dealing with the critical situation of COVID-19. In this session, Dr. Shah will be sharing his expertise and impact of top health concerns of COVID-19. Dr. Shah, we appreciate your time and insights and your expertise. Thank you, and I would like to turn this over to you at this time.
Hello. First of all, I would like to thank the organizers, my friends, Dr. Dominic Raj and Paul Conway, for giving me this opportunity to talk to you. So I have two hats on. The first one is as a past president of the International Society of Nephrology, a global society of kidney health professionals, which has as its mission advancing kidney health worldwide, and we want to do it together as a conglomerate. I also represent the George Institute for Global Health, which is a global health organization and has as its mission advancing the health of millions of people worldwide. Now, what is common to both of these organizations is the people's focus, the recognition, and the need to address inequities around the world. And finally, we want to do it through developing participative programs. I think these are critical and central to what I'm going to talk about, which includes community involvement in the various kind of things that we want to do together. I also live and work in India. Under normal circumstances, you will think of India as a vibrant, populous, colorful place, which is always interesting. But right now, India is hurting. I'm sure those of you who follow news in your own countries, normally you would not hear much about India. But these days, India has been on front page of many newspapers and in the top half on and landing pages of many news websites around the world. And the reason for that is the rapidly increasing COVID case count and the number of people who are dying of COVID. We are seeing the very striking images that you see in some of these news items, and that is something which really is reflective of some of the things that I'm going to talk about, and it informs some of the discussion. But let's get back to kidney. And if you were a kidney health professional or even a medical person in 1950s, this is most likely the textbook that you would be reading, the Cecil textbook of medicine. And the illustrative sentences shown here were essentially what we could do as medical professionals for people with kidney disease. We could only palliate them. And that was just around the time when dialysis principles had been recognized and it was starting to become available. From there, we go fast forward to 2007, which was around the time that kidney disease started to become recognized as something that kidney health professionals need to do advocacy around, which led to setting up of World Kidney Day in 2006. So we have been having World Kidney Days every year, and the first World Kidney Day editorial led by Professor Andrew Levy from Boston really called out the fact that chronic kidney disease was common and it was harmful, but it was treatable. Since then, we have moved quite a bit. The most recent World Kidney Day was just about a couple of months ago, and it has now become a global brand. It receives extensive attention on social media. It is highlighted by commemoration on important landmarks around the world that are globally recognizable. Major news outlets talk about World Kidney Day. Many governments, some of them shown here, and multilateral organizations such as the World Health Organization and the European Commission, etc., talk about World Kidney Day, and a number of global celebrities recognizable in different parts of the world spread the World Kidney Day message. And that is how we have got to from where we were about 15 years ago, and we are in a position to really champion the message of kidney health worldwide. However, that does not disguise this fact of the worst kept secret in global nephrology, that a vast majority of people with kidney disease are actually unable to receive the treatment that they need. And some of those numbers are shown here, and it should shock all of us. We also know from modeling data that chronic kidney disease is continuing to rise globally. Currently, it ranks about 16th on the list of the causes of death worldwide, but the Global Burden of Disease study estimates that it will rise up to the 5th position by the year 2040 rolls along. Most of this growth, mind you, is going to happen in those parts of the world that we call deprived countries or low resource situations. It is not that we don't know what to do with people with chronic kidney disease. We know, the global health community has been talking incessantly about it, is that more dialysis is not the solution, but we need to prevent the development of kidney failure. And we have the tools to do it. Some of those are shown here. But what is the challenge? The challenge is this. This is the world's biggest problem that we are facing, and it is how to provide healthcare to 7 billion people worldwide, of which 5 billion have no reliable access to essential care, and 2.5 billion will develop a serious disease before the age of 60 years. There is plenty of data from around the world that tells us that most people in the world with serious chronic diseases, including kidney disease, receive no treatment whatsoever. And that is a status quo we are no longer willing to accept. What are the challenges that we face? And this slide shows you just one of those in the form of the number of doctors per 10,000 population in different parts of the world. You can see that North America and Western Europe have between 25 to 32 doctors per 10,000 population. But when you come to parts of the world such as Sub-Saharan Africa and Southeast Asia, you see that the number of doctors is at least one order of magnitude lower, 2 to 3 per 10,000 people. What about chronic disease care in the 21st century where we are today? We know that every year tens of millions die prematurely and unnecessarily from preventable chronic diseases, including kidney failure. We also know that we don't have sufficient workforce, we don't have sufficient resources. Chronic disease care is bedeviled by great variation in quality, and it is high cost relative to the ability of the population to pay for it. So, where do we want to start? I think there are a number of things that we can do. But relevant to this gathering is to talk about community involvement. So what we need to do is to re-engineer the workforce that provides care. If you recall one of the previous slides where I showed you the shortage of doctors around the world, similarly, there is a shortage of nurses, there is a shortage of other trained professionals that can provide kidney care, or for that matter, care for any chronic kidney disease in large parts of the world. So we need to go back to the community and we need to re-engineer the community to convert them into healthcare provider workforce. We can do it. Now I draw your attention to the picture that you see with many of my slides. And you would recognize many healthcare providers in those pictures. All of those are actually members of the community. And I will talk about what we do and how we make it happen. We have found that this workforce that we draw from the community, of course, is larger because it is just there, and it is also much less expensive. And if you use the right tools with involvement of the community, we can actually reduce the variation in quality that you see often in care provision around the world. So here is an example. Here is the lady in white that you see. She is the community healthcare provider. She has a tablet device in her hand that she uses to assess risk of a person, in this case shown as the other lady sitting with her in front of her thatched home. So we have been working on this approach for the last 10 years in several parts of the world. What we showed, and we presented this almost 10 years ago now, is that the proportion of individuals correctly identified as being at high risk of developing a chronic disease, including chronic kidney disease, is actually higher when a healthcare worker does it if she, and in almost all cases of the kind of healthcare workers that we work with, it's a she. So if you take a primary healthcare physician who doesn't use any decision aids, they are able to identify a high-risk individual correctly in just about half the cases, whereas a healthcare worker, if she is given a simple decision support tool, her ability to identify this high-risk individual goes up by almost 12 percentage points. So you might ask the question, so what, even if they are correctly identified? Actually, it makes a difference in a big way, because then they are much more likely to receive appropriate treatment. And in this example, I'm showing you blood pressure lowering medications. So just about 29% were on appropriate blood pressure lowering medications before this healthcare worker encounter. And 6 months later, that proportion had gone up to 65. And what is even more satisfying is that the proportion that achieved actually target blood pressure also rose quite substantially, as you can see on the bar clusters on the right. So then, where to next? Now, what is the challenge in front of us? Our challenge is to make this therapy sustainable, to make it scalable, to make it affordable, But more importantly, to make it participative. So the communities have to participate. The people who have the problem, they are the ones who need to take charge of the response. And the other element of responsiveness is to make sure that whatever solutions we propose utilize locally available resources so that we do not propose a one size fits all approach but take it as they become available. So this slide shows you the work that we are doing now in several countries around the world in using this particular approach to manage number of chronic diseases, including kidney disease. And I think it is worth making the point that management of kidney disease cannot be undertaken in isolation, because kidney disease is one condition that always comes with a number of other comorbidities, or what we now call multimorbidity. It doesn't mean that we need to ignore kidney diseases, because kidney disease is often the canary in the coal mine that can, first of all, flag the presence of other complications. And therefore, when you manage kidney disease, or when we manage kidney disease, we develop these programs, we always develop an integrated risk-based program of management of kidney disease alongside all the other conditions that accompany kidney disease often. Let me now turn to describing to you the impact of COVID-19 on people living in disadvantaged communities in my country. So one of the things that we saw was the rampant spread of fake news and misinformation, even among slum communities, because if there is one thing which is present in every pocket in India, it's a cell phone. And they are able to connect with each other through social media platforms such as WhatsApp. And this WhatsApp, as I'm sure none of you need reminding, and other social media apps can be a tool for good, but can also be a tool for causing fear and panic, as happened in this instance. Lack of accurate information means communities are unaware of preventive and protective actions. And this is where I show you here in pictures how members of the community really came forward to fight and dispel much of this misinformation. So you can see on top a member of the community pasting on a wall a piece of information using comic strips. And similarly, you have in the middle bottom a lady who is holding out a panel that was developed actually by children on combating misinformation in COVID-19 around what is the right thing to do and what is not. And on the right, you see something that unfortunately has been so common throughout the world, which is the issue of xenophobia. Anyone who looked like a foreigner, who looked like the one that could be, that blame could be pinned on, such as someone who looked like they might have come from East Asian countries like China, they immediately receive blame. And in India, there are large sections of the population who especially come from the northeastern part of the India who were subject to this kind of discrimination. So, as you might imagine, and this has been highlighted in a number of publications now, that COVID-19 had a disproportionately large impact on patients with kidney disease, especially those who were on dialysis, because of lack of transport, which meant that people could not get to their dialysis facilities. Several dialysis units closed down because the staff were afraid and were not reporting for duty. Several dialysis units were actually closed down because those hospitals were designated as COVID hospitals. And a number of other reasons, which you can find now by simply Googling. Of course, dialysis patients are at greater risk for acquiring COVID-19 because of a number of reasons, like regular travel, interaction with dialysis staff. But again, here, the community really came forward, and we set up an Indian COVID-19 kidney health action group, which very quickly, in the early part of the pandemic last year, more than a year ago now, developed a hemodialysis unit preparedness checklist, which was rapidly disseminated to all the dialysis units in the country and contributed a lot to removal of a lot of fear and giving them confidence that there were safe practices that they could adopt which would protect both the healthcare workers and the patients in dialysis units. Similarly, a number of other groups also contributed. Stories about dialysis patients suffering during this pandemic were widely circulated in traditional news media, through social media, and through word of mouth. But as the last graphic here shows, again, the civil society swung into action and community groups, patient populations themselves, and non government organizations, including the organization that I work for, came together and organized appropriate relief measures for patients so that they could receive their appropriate dialysis. Community transports were organized so that patients could be ferried to and from their dialysis centers. What was even more heartening is that actually this issue, which was limited initially to low income countries, were also recognized by all the major global nephrology organizations around the world. And here I show you an appeal which was brought out jointly by the American Society of Nephrology and its president, Professor Anupam Agarwal, the European Renal Association, its president, Professor Carmine Zoccoli, and the International Society of Nephrology. And I had the privilege of being the president of the society at that time. And in addition to other things, the three societies called for the government agencies that are overseeing these dialysis centers to ensure that all the staff, nephrologists, and other healthcare professionals receive the appropriate support, and at the same time rapidly expand testing capabilities and provision of personal protective equipment. This is how we work together. So there are a number of ways in which COVID-19 has shown us possibilities for developing new partnerships. This has showed us that we can rapidly innovate. I didn't talk about telemedicine at all, which has paved the way for many people to receive healthcare at home and will possibly become the standard of care in the years from now on. It has also allowed us to develop some innovative low-cost technology solutions, which can now be used for primary care, emergency care, as well as rehabilitation. But we must remember that our focus is on preventing premature death and disability. We are not in the business, or we cannot even stop all deaths. Death is inevitable, but no one should die prematurely. For example, people who have chronic kidney disease, either early stage or late stage kidney disease. But this can happen only through cross-disciplinary scientific partnership. We need to engage with the people whose care we claim to provide. And those are the ones who will make change happen, as we have seen. So it is the civil society, it is the community in partnership with the entire healthcare provision community that can develop appropriate responses and then go to the policymakers, the lawmakers, to make change happen. And that change needs to be one that will stick. COVID-19 has shown us the need to call for change in our healthcare system now. We must not lose this opportunity. And that can happen only through global collaboration, engagement, most importantly, with social impact investment sector. We must stay focused on implementation, scale up, and sustainability. With that, I come to the end of my presentation, and thanks a lot for your attention. Like I said, collaboration is key, and I and my colleagues in India and around the world are open to such collaborations. You have my email address on this last slide, and even otherwise, Dr. Dominic Raj and Paul have my email contact information. So if you want to reach out to me, please do. We must work together and defeat all the devils that are standing in front of the patients receiving the care they deserve and stay healthy for as long as they must. Thank you very much.
Dr. Shah, thank you for taking your time to share your insights and expertise on COVID-19. Thank you.